In this video, we'll review the 4 approaches to the thoracic paravertebral block. The paravertebral space is a triangular-shaped potential space. Its borders include the internal intercostal membrane, which is continuous with the superior costotransverse ligament, transverse process, and pleura. When we place local anesthetic in the paravertebral space, we block the dorsal and ventral intercostal nerve roots as well as the sympathetic chain. This results in a very reliable chest wall block that can be used for analgesia and in some cases surgical anesthesia. We can perform the paravertebral block using a transverse in-plane, transverse out-of-plane, parasagittal in-plane, or parasagittal out-of-plane approach. My preferred positioning for all 4 of these approaches is to place the patient prone with the block side arm down and a pillow underneath the chest to move the scapula out of the way. I've found this position to be the most ergonomically effective as it allows you to steady your hand on the patient's back for improved precision and control. Patients with rib fractures are often unable to move completely prone, and in these cases, rolling the patient as far lateral as possible with the fractured side up is usually sufficient. In patients already in the lateral decubitus position for surgery, the OR table can be tilted towards the operative side to simulate prone positioning. In most adults, I prefer to use the curvilinear probe for paravertebral blocks because of the broader field of view and improved visualization of structures deeper than 4 centimeters. On children and smaller adults, you may have better visualization with a linear probe. For the transverse in-plane approach to the paravertebral block, the probe is placed just lateral to the posterior midline and the transverse orientation along the oblique angulation of the ribs. We advance the needle in-plane from posterior lateral to anterior medial towards the paravertebral space. It's important to make sure that your needle is directly under the beam of the ultrasound, since fanning the probe cephalad or caudad is likely to place a rib in your path. At this point, our needle has passed through the internal intercostal membrane and we'll see anterior displacement of the pleura with our saline test injection. We see continued anterior displacement of the pleura as we administer our local anesthetic. In patients with very poor lung compliance, such as this patient with trapped lungs secondary to fibrosis, you may not see movement of the pleura with injection, even though the tip of the needle is clearly in the paravertebral space. Our regional anesthesia service began offering paravertebral catheters to patients with rib fractures in February of 2022. I found that I could not proceed with a transverse in-plane approach to the paravertebral catheter for patients that required rib plating, since this will place the catheter in the surgical field. However, I preferred the broader view of pleura with the transverse oblique view compared to the parasagittal view of the paravertebral space. From this dilemma, the transverse out-of-plane approach to the paravertebral block was developed, which prior to this was only mentioned in a cadaver study. As with the transverse in-plane approach, for the transverse out-of-plane approach, the probe is placed just lateral to the posterior midline and the transverse orientation along the oblique angulation of the ribs, and the paravertebral space is centered. Using very careful hydrodissection, we'll advance our needle from posterior to anterior until we pop through the internal intercostal membrane and visualize downward displacement of the pleura with our saline test injection. This downward displacement of the pleura continues as we administer our local anesthetic. To perform the parasagittal in-plane approach, we'll place the probe just lateral to the posterior midline in the parasagittal orientation with a slight lateral tilt. This tilt brings the rib into view on one side of our screen and the transverse process on the other side, allowing visualization of the pleura. Without this tilt, the acoustic shadow of 2 adjacent transverse processes would impede our view of the pleura. With a slight lateral caudal tilt, we see the more superficial square-shaped transverse process cephalad, the deeper and round-shaped rib caudad, and pleura in between these 2 bony structures. After we advance our needle past the superior costotransverse ligament into the paravertebral space, we'll observe anterior displacement of the pleura with injection. A common mistake with the parasagittal approach to the paravertebral block is to place the local anesthetic between 2 ribs, such as this catheter intended for the paravertebral space on a patient with rib fractures undergoing rib plating. Intraoperatively, this catheter was found in the intercostal space rather than the paravertebral space. In this intercostal view, thought to be a parasagittal out-of-plane paravertebral block, notice that all bony structures are round at the same depth. We do not see the superior costotransverse ligament and have clear visualization of the pleura at all interspaces. To perform the parasagittal out-of-plane approach to the paravertebral block, we'll place the probe just lateral to the posterior midline in the parasagittal orientation, again with a slight lateral tilt to allow visualization of the pleura. Using very careful hydrodissection, we'll advance our needle from posterior to anterior until we pop through the superior costotransverse ligament into the paravertebral space. In this particular block, once we advance our needle past the superior costotransverse ligament into the paravertebral space and administer our test injection, we see anterior displacement of the pleura at both our targeted level and the adjacent level.